Yeah, so at this meeting I gave an educational presentation on the mechanism of relapse and progression in relapsed refractory acute myeloid leukemia. I think the main message is that the genetics and cytogenetics typically changes at the time of relapse. It's really important to do both the cytogenetic analysis and also the whole genome, NGS analysis, sequencing analysis, to identify if there's any targeted therapy that this patient can go in the setting of clinical trial or off clinical trial. So I present multiple examples where, for example, complex cytogenetics and PVC mutations are being selected with intensive chemotherapy and maybe less so with non-intensive therapy. I also have shown that in the context of targeted therapy, for example, with IDH inhibitors, BSO2 inhibitors, and FLT3 inhibitors, there's common disappearance of the target lesion, such as IDH mutation or MP1 mutation or FLT3 mutation, but there's emergence of the clones with what we call signaling mutations, such as RAS mutations, FLT3 mutations, sometimes in the context of BSO2 inhibition. And so it's really important to track those and to understand how to best to manage that. So additional point with the kind of approval of the menin inhibitors and the salvage setting, we now know that there are more subsets that can be sensitive to this therapy in addition to KMT2A rearranged and NPM1 mutated leukemia. And I showed the example of the NUP98 rearranged AML, which could be only diagnosed using the novel technology called the optical genomic sequencing, OGM, that can identify cryptic translocations and rearrangements at fairly high sensitivity. I also showed some other mechanisms of resistance, for example, to menin inhibitor therapy with mutations in the binding site, and also specific to, for example, IDH inhibitor therapy, some mutations, again, in the binding site of the inhibitor, isoform switching, but also non-targeted mechanism, again, with RAS mutations and mutations in differentiation-associated genes, such as CBP alpha, for example. So the point is that the mechanisms of relapse are many and they're quite diverse. I have demonstrated with the use of single-cell DNA sequencing how we can better understand the clonal progression on the level of individual clones and how we can track those on the level of DNA and also the RNA levels, which of course requires additional studies and understanding. So it's also the mechanisms of resistance are specific to the therapy that is being used. And now we're learning more about escape from specific targeted therapies and how best to track those. Fortunately, we have more and more targeted therapies available, and I think at the relapse, the goal is really to get patient into remission and to go for the transplant if feasible. So I think use the targeted therapy rather than use of chemotherapy is becoming more and more prevalent at the time of relapse. And so using the tools that we have, it's really important to understand molecular mechanisms of progression.